Hello, everybody. It's nice to see so many of you on this talk. As you can see by the slide, my name is Cindy Ketcham, and I have my own company called NCME Consultants. NCME stands for Together in Italian, and I also am the Director of Nursing Education for the New Mexico Bridge. And you can see that we're going to talk about harm reduction today. And I really enjoy talking about harm reduction because it's not one of those topics that any of us need to learn about multiple medications or calculations. It's a pretty simple, straightforward topic. And we'll get started. So your learning objectives today, there are two of them, and that is at the end of this presentation, you'll be able to explain what harm reduction is as it relates to healthcare, and you'll be able to identify two harm reduction approaches in a community. And just a little bit about me. I've been a nurse for about, I think I graduated in 1987, if my memory serves me, and I've worked in pretty much every capacity of nursing, from emergency care, surgery, leadership, and now addiction medicine. I've been in addiction medicine since 2014, and I really got introduced to it when I became the health service administrator for San Juan County Corrections. And I was responsible for adult and juvenile and any services that were related to treatment. I rescue special needs and senior dogs, and you might hear some of them barking in the background. The truth is that I have 12 and a 13th one on its way this week from Arizona. So it keeps me pretty busy. I live in Santa Fe, New Mexico. I've lived here just about 8 years. I'm originally from just outside of Buffalo, New York, in a town called Lockport. That is, has its notoriety for the locks on the Erie Canal. I'm married with 4 adult children and 9 really cute grandchildren. I'm a mother of an adult child with substance use disorder, just so that you can kind of get a feel for why I talk about these things about addiction. I did want to say that if you have a question, ask it when that pops up in your head, and we can discuss it at that time. The most important thing of all of this, I'm a diehard Buffalo Bills fan. I have always been, I'll always be. I'm from an Italian background, and in Buffalo, we're known as the Buffalo Bills Mafia. So harm reduction, what is this, right? We really want to know what this means when we talk about it. And it's very simple. If you just reverse it, it says reduction in harm. And that's really what it means. It means that we acknowledge that there are certain behaviors, such as substance use, sex work, or other risky sexual behaviors, that may persist despite efforts to discourage them. It's non-judgmental. It is not stigmatizing in any way, shape, or form, and it's not criminalizing. It mitigates or decreases the potential harm through different strategies that I'll show you. And we have a little bit of a background on harm reduction that's pretty interesting. So it has been multiple movements and strategies as far back as the 1960s. If I say the word Black Panthers, they come to mind with kind of being aggressive or violent, but in truth, they sponsored many, many programs like free breakfast for children and several health clinics. There's also this other one called the Young Lords Acupuncture Program, and that was specifically for heroin users in the South Bronx. In 1970, there was this feminist activism, and there was a fight for reproduction. Now, remember, in 1970s, they did things like ban my bra and all that stuff, and we've become a little bit more civilized now, and we do things like we protest, peacefully protest, and now the big protest is this whole thing about my body, my choice. And that is one way that people can get their thoughts out there to the public. And we know that that's very obvious in the whole Roe versus Wade saga that we're dealing with. In the 1980s, there were grassroots and activist response to the AIDS crisis. Interesting enough, I lived in San Francisco, and San Francisco was the mecca for AIDS and HIV. And as a nurse at Stanford, we knew very little about how to treat that disease. And through harm reduction programs, they were kind of like ostracized from society, outcasts. People were afraid that they'd get that disease. And so these harm reduction approaches that they used in San Francisco really helped educate people. And how does it benefit our society? Well, the truth is that um, there is scientific data, research data, real world data that shows that if we engage in these harm reduction strategies, we can significantly reduce things like HIV, wound abscesses, overdose from death by using harm reduction strategies. Oops, sorry, I overtalked myself. And we also noticed that there has been this uptake of addiction treatment services, and they are part of harm reduction strategies. So I wanted to share this with you. This is from my hometown, Lockport, New York, and it is a tale of epic harm reduction failure. This is the building built long time ago, over 100 years ago. It was first known as the poorhouse, and people that had no money, had no home would go to this poorhouse, and it'd be the end stages of their life, and most people died there. So this company came in, and oh, I'm sorry, I skipped a couple things. So it was then abandoned because they built a new facility in the outskirts of town. It then became known as the infirmary, and I worked there. And the infirmary was in a nursing home, basically. And instead of private rooms, they had like dorms, and so multiple beds and really like kind of archaic ways to shower and that type of stuff. But that survived for a long time, and it was very successful. It's now been vacant for about 20 or 30 years, and it's fallen into great disrepair. There's this building and there's another almost the same size building on this property. In 2019, this company that specializes in addiction recovery and treatment offered to buy the building and all the buildings and the land surrounding it for a pretty big chunk of money. And what their vision was that they were going to take these dorms that they had in there and turn them into more private areas, and mothers and children would then be able to stay there as the mother went through treatment, and the children would get nutritious meals, get medical, go to school, get help with their school homework, and they'd be safe in that environment. And then after that mother would get through recovery, there was then the second building that would house studio apartments, and up to 30 families could live in that building, and they would be charged low or no rent. And it really was kind of this big harm reduction thing to utilize a building or buildings that had been vacant, and they were going to renovate and make it beautiful. Unfortunately, the people of the city protested, and they had this belief that it was a good idea, but not near them. They thought that if that was put into place, that there'd be more crime in that area, when research shows that crime actually is lowered or stabilized when these recovery centers are built. They believed that there'd be dirty needles everywhere. Well, this building would house a safe needle exchange, so there wouldn't be needles on the street. And then they said their other belief was that it would reduce home value. And research shows that it actually stabilizes home value because it's seen as a very good thing to have in your community. But needless to say, the city council believed the people of the city, and they turned down this very audacious offering it from this company. And now the building is really in profound disrepair. And it's basically used as a place for people to come if they can get in, and they get in through broken windows that aren't boarded up, and they come in there and they actually use their illicit drugs, and they stay in there until the police come along and kick them out. There's no electricity, so they burn candles, and they burn propane grills, and it's really a big fire risk. And there's no way to prevent a fire from starting. And as we all know, the people that are there illegally will panic, and then they will flee the scene, if you will. And now we have a fire potential. So I really think that it is a tale of epic harm reduction failure. So there are a bunch of top harm reduction approaches, and you can see these if you look across the screen. Needle exchange programs, access to safer sex supplies, medications for addiction treatment. And when we talk about medication treatment, addiction treatment, we particularly talk about naltrexone, buprenorphine, and methadone. Harm reduction approaches will supply fentanyl and xylazine strips, and they'll also have Narcan, also known as naloxone, at their overdose prevention sites. We know that the cycle of harm is something that we consider when we look at addiction and addiction in our community. We arrest people for drug possession, and that begins this cycle of harm. 1 in 5 incarcerated people are serving time for a drug offense. 83% of people currently in custody are in custody for personal use possession. And if you know anything about personal use possession, it's usually a very small amount, but they include in that any of the paraphernalia, like the pipes, torch lighters, etc., that go along with that. So this incarceration starts this vicious cycle of instability and trauma for millions of families. It's separating families unnecessarily and ultimately destabilizes our community. I'm going to give you a little thing on how this goes. So we start with drug use, right? And that drug use leads to incarceration. And that incarceration then leads to a criminal record. And then we look at employment difficulties. It's very, very hard to get employment when you have a criminal record. Okay, and that causes this significant trauma to the entire family. It then leads to this increased risk of addiction for self-preservation, that then causes them to use drugs, and then you can see that cycle continues. Now there's incarceration, destabilization of the family, and it just continues to go around. It's just this cycle of trauma. So the data doesn't lie when we talk about this stuff. If we look at people in state prisons that have had a substance use disorder, half of those people will be in there specifically for their substance use disorder. Only 1 in 10 of them will ever receive treatment. 1 in 10. That's a terrible percentage of people. Then we go and we look at 49% get a substance use disorder in the year before admission. Think about it. Think about the story that I told you about my daughter. 2 years prior, she was arrested. 10% of them will receive clinical treatment. Example, my daughter again. During the time of arrest until conviction, she had gotten into a program. She had improved her credit, had a really good job with significant advancement, had stabilized housing, excuse me, all those things that take people out of that cycle that I just showed you earlier. The truth is this, that people are most successful when they have access to both medication for addiction treatment and counseling together. So you see that's at 16%. And this includes things like self-help groups, peer counseling, substance use education, and medication for addiction treatment. And there's very few drugs that we use in medication for addiction treatment. Naltrexone, buprenorphine, and methadone. Does harm reduction discourage people from seeking treatment? Well, we know that harm reduction is both a social movement and a way to provide valuable services to people who might not otherwise seek treatment because it offers that education. And we know that people fear what they don't understand. By making drug use safer, harm reduction can prevent some of the negative consequences that define addiction. Things like wound abscess, uh, overdose, death, etc. The first step to recovery despite chaotic drug use. And when I say that, this is what I mean, that if they have a safe place, if they have a place that they can get clean needles versus dirty needles, then they're more likely to then think about entering some type of recovery. And harm reduction, remember, people don't have to be drug free to enter some type of harm reduction program. They'll continue the journey of recovery through small, slow steps that ultimately reduce the harm associated with drug use. So the answer is no, it does not discourage people from seeking treatment. In fact, it brings people into harm reduction, and therefore then the seed is planted, if you will, for some type of treatment. And is there really a need? Well, according to the Center of Disease Control and Prevention, we know that more than 107,000 people in the United States died of drug overdose in 2023, with roughly 75% of those people dying from deaths involving opioids. And there is preliminary data out now for 2024, and I have it, but I didn't want to give it to you until that was really definitive data, because that can change. But it's looking like that we will either plateau from 2023, or we might have a slight increase. And that slight increase doesn't look like it's going to be significantly important. 653,104 people experienced homelessness in the United States in 2023. That number represents a record high tally and a 12% increase from 2022. And we believe that data is just going to continue to go up until we really get this opioid crisis under control. 1.16 million Americans are arrested annually for drug-related offenses. 244,000 of those Americans are sent to prison. What is important to note that in some states, including the state of Arizona, people are charged for each day they are incarcerated, whether it's jail or prison. And currently that charge now is $63 a day plus tax. And if they cannot pay that on release, they are charged 300% interest until that debt is paid. And so what we are doing by incarcerating people, and I'm not saying everybody deserves to not be incarcerated, but there are people that probably could be on home monitoring, work release, those type of things. They are now getting out of jail with this huge debt, depending on the number of days they stay. So like I told you, my daughter's in there for 75 days. So it's $63 plus tax. She's looking at a greater than $5,000 debt that she gets for being incarcerated. So you can see where it sets them up for failure. Most of them lose their housing, they lose their jobs, and now they have this huge debt. And that's why I think, and many others think, that incarcerating people for drug offenses of personal use, so tiny quantities, is not the answer to making them good citizens, if you will. Now it sets them up for failure the minute they are released from that jail. This is a number that really makes me kind of like sick to my stomach. So many children were without homes in America last year. And if you have homeless children, you have them not going to school, not getting medical care, not having nutritious meals. For the mother, that homelessness places a huge burden on them, in addition to the fact that they have a substance use disorder. So you tell me about the need for harm reduction in America. Do you think that there's a need? I bet most of you are saying yes. So harm reduction is not just about addiction. It's also about our community. What is our community doing to reduce the harm of people that have a substance use disorder? So here are examples of them. The use of sunscreen, the use of seat belts, bike helmets, speed limits, condom use, and cigarette filters. And I think the one that you know the best is this one: the provision of toothpaste and toothbrushes when people are getting their teeth cleaned. And that is the one that I always think about when I talk to people that are homeless and they have Medicaid and they go to the dentist and the dentist provides them with a toothbrush and toothpaste. Probably the only toothbrush and toothpaste they will get until they see a dentist a year later. So we know that harm reduction can save lives. And here are some harm reduction approaches that you can take to it. Learn from people with lived experience. In my profession and in my field of nursing, I talk to people all the time about their experience. I talk to my daughter about their experience. I'm always trying to find out where are the gaps that harm reduction might be able to take care of. We want to promote leadership and staff buy-in. It's important for us to enter in these harm reduction strategies without bias or stigma. We address stigma when we look at harm reduction. We look at stigma in ourselves. We look at stigma in our organizational culture, and we look at it in our own society. We assess the local, state, and organizational policy landscape. So we see what's in law, if you will, to help people that have an addiction. We identify opportunities to engage in policy reform. And this is important. This is really part of being a citizen that really cares about your community. So you'll look at those policies and you'll talk to your senator, congressman, about ways that we can engage in that reform. We develop collaborative relationships with existing harm reduction providers. But first, you have to know where they are and who they are. We take an incremental approach. And by that, I mean, don't take on everything that falls under that harm reduction umbrella at once. Focus on one. Maybe look at safe needle exchange or safe condom use, and take that and work on that and get really good at it. Become that subject matter expert, and then take on another one. And pretty soon you'll be taking on more and more of those harm reduction strategies until you've taken on as many as you can. And all that while, you'll be looking for new ones to add to your community landscape. And just send that. And always assess those opportunities to provide medication for addiction treatment, also known as medication for opioid use disorder. Join local, regional, and statewide efforts. I was just a couple weeks ago at our capital here in Santa Fe with a group of people protesting for some more harm reduction approaches. I don't like protesting. I'll tell you, I don't like it because I'm always afraid somebody's going to drive by and shoot me, but I still do it because I think it's important for Santa Fe and the areas that we surround. I wanted you to meet somebody, and her name is Louise Vincent. I met her probably 8 years ago at a conference in Dallas related to substance use disorder, stigma, and stigma reduction. If you look at this picture, kind of guess how old you think she is. When I first met her, I thought she looked much older than her actual age. I will admit to you that I kind of stigmatized her because she was pretty difficult to look at. She was kind of like looked like that she still had an addiction. And here's what I learned about her. I sat with her for about 2 hours and listened to her story. She's 47 years old at the time that picture was taken. She used street drugs since she was 13 years old. She recently had a daughter die from a fentanyl overdose. Her daughter was 19 years old. She has been unable to sustain recovery since she was 13 years old. That's a long time to still be using drugs. Her drug of choice or preference is fentanyl. She was exposed to fentanyl that was laced with xylazine, and xylazine is a veterinary medicine used in horses and cattle. She suffers with these non-healing, disgusting looking open wounds on both her arms because she was injecting street fentanyl that was also laced with xylazine. She's one of the leading voices in the United States pushing to humanize and really for substance use disorder and harm reduction. She does this all while still using drugs. She is one of the first people to implement harm reduction in her community. Currently, she has created this Urban Survivors Union, and they have a facility, a small one, that they provide meals, coffee, test strips for both fentanyl and xylazine. And she's just now opened up within their facility a xylazine wound care treatment part. She also has a safe harbor, and that safe harbor is for people to be able to exchange dirty needles for clean needles. And that safe harbor is in a different location than all those other services I mentioned earlier. Well, the future depends on what we do in the present. And I think it's more true now than it ever was. And in saying that, we talk about, there's a couple organizations or coalitions. I only mentioned two of them for the sake of time, and we really have to keep moving along on this. There's this National Reduction Coalition that is centered around 8 guiding principles that it accepts that for better or worse, whether illicit or illicit drug use, it's part of our world, and this organization chooses to work to minimize harmful effects rather than simply ignore or condemn them. It establishes quality of individual and community life and well-being, not necessarily cessation of drugs. Think about Louise, as the criteria for successful interventions and policies. It ensures that people who use drugs and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. Again, I introduced you to Louise and the fact that she still uses drugs, yet she's been on NRP talking about addiction. She's talked in Congress about addiction. She's talked at many conferences about addiction and her story. She's pretty amazing. It also recognizes that the realities of poverty, class, racism, social isolation, past traumas, sex-based discrimination, and other social inequities affect people's vulnerability to and capacity for effectively dealing with drug-related harm. Think about the mother who is homeless and she has an addiction. On top of her drug addiction and that need to most often steal or sell herself to be able to support her habit and have any money, she now worries about the homelessness of her children. That's a huge burden to carry. This coalition understands drug use is a complex, multifaceted phenomena or a disease that encompasses a continuum of behaviors from severe use to total abstinence, and acknowledges that some ways of using drugs are clearly safer than others. We know that clean needles is definitely a harm reduction practice that works very well. It calls for non-judgmental provision of services and resources to people who use drugs and communities in which they live in order to assist them in reducing harm. So there's more of these. So this continues with, it affirms that people who use drugs called PWUD, people who use drugs, themselves as primary agents of reducing the harm of their use and seek to empower these people to share information and support each other's in strategies which meet their actual conditions. Remember, we talked earlier about um, talking to people about their experience so that we can fill in the gaps with harm reduction strategies to help and support them. It does not attempt to minimize or ignore the real and tragic harm and danger that can be associated with illicit drug use. And I put their information here in case you wanted to find them on the internet or send them an email. They are very, very quick to give you any information that you want. They're very easy to work with. They'll answer any of your questions. They're pretty expedient on getting back to an email if you send it. I sent one 2 days ago, and within 2 hours, they had answered my email and the question that I had. This next one is called the Substance Abuse and Mental Health Service Administration. You guys probably know it as SAMHSA. And SAMHSA has many more things than guiding principles. They have pillars, principles, and core practices. I will go over them pretty quickly because I do have some things that I want to go over with you. So they are guided by people who use drugs. They embrace the inherent value of people. They're committed to deep engagement in community building. They promote equity, rights, and reparative social justice, and they offer the lowest barrier access and non-coercive support. I want to mention here that healthcare and healthcare providers are the number one barrier to people seeking treatment or staying in treatment. And the reason for that is that healthcare providers stigmatize people, and they stigmatize them to the point that they don't offer necessary treatment. They may have a bias against treatment. They may not think it works. They may think that they're not deserving of treatment. And we need to continue to talk about stigma, learn about stigma, and learn about stigma reduction. The SAMHSA focuses on any positive change as defined by the person. So if that person comes in and they say to you, I only used 50 grams of fentanyl yesterday instead of 55 grams, or 100 instead of 200 grams, SAMHSA sees that as a positive change, and it's a reason to celebrate their success on that. The 12 harm reduction principles are call for providers to respect the autonomy, practice acceptance and hospitality, provide support, connect family, provide many pathways to well-being across the continuum of care and service, value practice-based evidence and on-the-ground experience. So in other words, if you have a provider that has been using a medication for opiate use disorder, substance use disorder, you need to hear him. His plan might not have been concrete in practice-based evidence, but it certainly is on-the-ground experience, and that provider has some very good insight into the care and treatment. You want to cultivate relationships, assist, not direct, meet that person where they are, and promote safety. Engage first. So listen to understand, get their story, let them talk about it, and then begin engaging in everything else. Prioritize your listening. We so often as healthcare providers listen a bit and then we quickly respond, because our number one goal is to treat that patient, to provide treatment for them, if you will. Work towards system change. So look at your facility policies. Do they have any policies that relate to harm reduction? Whether it says harm reduction or not, you know what that looks like, and you can look at those policies and see what they have. Their 6 core principles are much greater to talk about. So I'll leave this up on the screen for like a second or two, and you can kind of glance over it. This is being recorded, so you can find that recording anytime you need that. We know that examples of this include safe needle exchange. Safer settings are things like day centers for substance use disorder, social places, and harm reduction services that have access to safe and secure housing. safer access to healthcare. We want to provide that in non-stigmatizing approaches. We want to have lower barriers to treatment and mobile and take-home medications. Methadone is a tricky one to take home when it's used for substance use disorder, but buprenorphine is much easier to get a prescription so that they don't have to go to clinic every day to get their methadone. This one's kind of blocked by my screen, so I can't see what it is, but you can, I'm sure. I just want to see if I can read this. Nope. No. That one's up there. And sustainable workforce and work field. That just means that we're offering living wages and essential benefits for people that engage in harm reduction, and that they will provide training and technical support. You can find your own training just by accessing the SAMHSA website, and I have that at the end of this. We want to have sustained infrastructure, so we need senior leadership approval and engagement to make those happen where we are. This is the SAMHSA website. You can Google it and it'll come up easily for you to go to that. They have a lot of education on that website. You just kind of have to continue to drill down and find what you're looking for. They have things like opioid use disorder, buprenorphine treatment, methadone treatment, and you can find all of that information just on that one website. The opposite of addiction is not sobriety, it's connection. And that connection has to be that human connection. And we know that that is possible when we support and engage in those harm reduction strategies. So I just wanted to talk about this briefly. This is the cycle of addiction. And you can see that there's no beginning and no end to that. It just keeps going round and round until that patient gets into some type of treatment. And when they get in treatment, we use this model. This is called the stages of change model. The first one is pre-contemplation. It's when the patient is in denial that they even have a problem. They'll say things like, oh, I just use it occasionally. I only use it at parties. My friends have a problem, but not me. That is the first stage. The next one comes along, and that's contemplation. And these are all my labels to it. It's where they have that aha moment where they say stuff like, maybe I am using too much. Maybe I really need to seek some help. And that then leads us to this preparation stage. And this preparation stage is basically when they're getting transportation, work, and support, often their spouse or their friends, and that type of treatment that they decide on. The next one is when the rubber hits the road. This is when they engage in a program. They're consistently going. They're having negative drug screens. They're doing everything they can to continue on this journey while still being without using that substance. And that action phase is about a year. On a good day, it's about a year for most patients. When we get into maintenance, that's after 5± years. And this is when they are no longer using anything. All their drug screens are negative. They are well into their recovery. They're embracing the change. They then go on to one of two things, relapse or recovery. And we need to know that if they relapse, that's not a moral failing. Oftentimes, I'll see patients that come into clinic and they're on their 5th, 8th time trying recovery. What's important to look at is this. When we look at people that relapse, we know that it's an upward spiral. They learn from each relapse. And by that, I want to say that they don't go back into pre-contemplation. They already know they have a problem. They probably do not go into contemplation, but they really do go into preparation. They need to get all that stuff together, and then they cycle into addiction and maintenance, and hopefully eventually recovery. And that's our ultimate goal. And they then can exit this whole stages of change model. So it's a pretty simple model to learn, and the work really is done by the person that's now entered recovery. And I just talked about all of this, so we'll go past that. Remember that it's not a moral failing. It's part of their journey. Change is not something that most people are ready to do right away. You have to plant that seed, plant it anyway. You might not see the fruit of your labor, but somewhere, someday down the line, somebody is going to benefit from what you instill in that person. Most of all, respect the patient's choice. Well, these are basically your take-home points. Harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. It is not a cure-all. It's neither condones nor prevents the use of street drugs, because people will say, oh, you give them clean needles, you're just promoting their drug use. We're not promoting it. We're basically stabilizing the threat of harm to them by infection and wound abscess. Harm reduction is a movement of social justice. It's built on a belief in and respect for the rights of people who use drugs. Keep in mind, harm reduction can be the first step in that patient seeking recovery. It incorporates a spectrum of strategies that I already talked to you throughout this presentation. So here's my take-home points for you. This is Josh Allen, and he received the MVP at the end of the season, not because his team went to the Super Bowl and won, but because he was such a good leader, such a kind person, does so much for his community, continues to be a person that is a wonderful role model for the team and for society and for me. So when he received his MVP, this is what he said when he accepted it. He said, be good, do good, God bless, and go Bills. And I had to put him here because he does harm reduction things in his community service that he does. And he's always a person that his team looks up to. That's why he got the MVP. So here's your take home. It's very close to final here. It's easy to stand in a crowd. So it's easy to do nothing. It's easy to turn a blind eye, but it takes courage to stand alone. And someday you might have to go to your leadership and say, you know what? I don't think we do enough for harm reduction. We're focused on one thing, and that's treatment, but we don't offer those other resources that are available. And so you want like your case manager, your social worker, or your front desk to have literature that you can give to patients when they leave that day. And that is all I have, guys. It's a wrap.